This video will summarize the article titled, The Value of a Head Turn in Neurolocalization. Starting with the introduction, head turn and pleurophotonus are often used interchangeably to describe postural abnormalities in cats and dogs during neurological examinations. A head turn is when the head and neck are deviated on the horizontal plane, whereas pleurophotonus involves a twist of the head, neck, and trunk to one side. Other terms used to describe these deviations include torticollis, lateracollis, and scoliosis. There is no direct equivalent term used in human medicine for a head turn, but lateracollis is the closest in humans. The presence of a head turn in cats and dogs is attributed to lesions in the forebrain, particularly the rostral thalamus. However, the understanding of why this manifests remains unknown. Our aims were to identify the central nervous system regions associated with head turn with or without body turn in patients with neurological dysfunction and determine whether lesion location can differentiate between head turn and pleurophotonus. We also aim to identify any other postural deviations associated with head turn, such as head tilt. Going through the materials and methods, this multi-center prospective observational study was carried out in several universities and vet clinics. The study focused on dogs that presented a head turn upon admission with photographic or video evidence. In order to assess the head turn, the degree of rotation categorized by less than 45 degrees, 45 degrees, 90 degrees, 90 degrees, and 90 degrees, 180 degrees, the site of the head turn, and the concurrence of body turn or head tilt were evaluated. Neurological examination, MRI, or CT was required to determine affected anatomical structures and lesion localization. Specific subregions such as forebrain, brainstem, cerebellum, or a particular spinal cord segment were identified based on imaging data. Dogs' details and suspected or confirmed diagnoses were also noted. Dogs without structural changes, multifocal areas on imaging, or large enough to affect more than one subregion were excluded. The statistical analysis used the Fisher's exact test with less than 0.05. For the results, a total of 49 dogs were included in the study, 24 of which had an imaging localization to the forebrain, 9 to the brainstem, 9 to the cerebellum, and 7 to the cervical spinal cord. The range of lesions included intraaxial solitary mass, ischemic infarct, extraaxial solitary mass, non-traumatic hemorrhage, atlantoaxial subluxation, syringahid row, myelia, acute hydrated non-compressive nucleus pulposus extrusion, suspected seizure-induced change, intervertebral disc protrusion, and traumatic spinal cord injury due to a dog bite. The distribution of the disease processes in relation to imaging location is shown in Figure 1, and the distribution of combinations of head and body postures based on imaging location is shown in Figure 2. Of the dogs with head turn only, 13 out of 15 had forebrain disease. Of the head turn and head tilt only cases, 5 out of 9 were found to have brainstem disease. Lastly, of the dogs with a head turn, head tilt, and body turn, 6 out of 13 had cranial cervical disease, and 4 out of 13 had cerebellar disease. The site of turn or tilt relating to the imaging localization is presented in Table 1. The degree of head turn did not appear to be associated with the presence of a body turn. A graph depicting the presence of a body turn in relation to the degree of head turn is presented in Figure 3. Dogs with forebrain disease, N equals 24. Of the 24 dogs with noticeable forebrain lesions, 11 were located in the telencephalon only, 3 were located in the diencephalon only, and 10 affected both telencephalon and diencephalon. The underlying causes were intraaxial in 21 cases and extraaxial in 3 cases. The ipsilateral head turn was identified in 23 cases, and in 1 case, the head turn was contralateral due to a seizure-induced change. A concurrent body turn was identified in 10 cases, all of which were ipsilateral to the side of the imaging location. A concurrent head tilt was identified in 2 cases, 1 telencephalic-only case, and 1 case with both telencephalic and diencephalic involvement. Neurological examination localization was suggestive of the neurolocalization compatible with the lesion found on advanced imaging in 38 cases. Compulsive circling was identified in 20 cases. Other findings attributable to a forebrain localization included altered mentation, altered behavior, aversion turning, hemi-neglect, eating, proprioceptive deficits, and menace response deficits. Images of each posture with forebrain pathology can be found in Figure 4. Dogs with brainstem disease, N equals 9. 9 dogs had noticeable lesions affecting the brainstem, with 5 affecting the medulla oblongata only, 3 affecting the midbrain only, and 1 having extensive pathology affecting the midbrain, pons, and medulla oblongata. An ipsilateral head turn was identified in all 9 cases. A head tilt was identified in 7 cases. The 4 dogs with ipsilateral head tilt were located in the MO group, and the 2 contralateral head tilts were identified in the MI group. A correct lesion localization based on the neurological examination was identified in 6 cases. Other signs of brainstem disease included proprioceptive deficits, change in mentation, positional nystagmus, and ipsilateral circling. An example of the most common presentation with brainstem pathology can be found in Figure 5. Dogs with cerebellar disease, N equals 9. All head turns were ipsilateral to the side of the lesion, with 6 out of 8 dogs having a head turn greater than 90 degrees. A head tilt was identified in 7 out of 9 dogs, and a body turn was identified in 4 out of 9 dogs. A correct localization on neurological examination was identified in all cases. Other aspects of the neurological examination included ataxia, postural response deficits, positional ventrolateral strabismus, and vertical spontaneous nystagmus in the eye ipsilateral to the lesion. An example of the typical posture seen in cerebellar cases can be found in Figure 6. Dogs with cervical spinal cord disease, N equals 7. All cervical cases had a contralateral head tilt, and a body turn appeared contralateral to the imaging localization. A head turn was identified in all cases. Localization based on neurological examination was correct in 5 cases. All dogs with lesions involving the cranial cervical area and the 1 dog with extensive cervical disease had head tilts present. Other clinical signs identified in dogs with cervical lesions included proprioceptive deficits, tetraparesis, hemiparesis, and Horner syndrome. An example of the most common presentation seen with cranial cervical pathology can be found in Figure 7. Going through the discussion, this study aimed to determine whether combining a head turn with other postural abnormalities could aid in neurolocalization. However, it was not successful as head tilts and body turns were present in all broad locations of the brain and cervical spinal cord. An isolated head turn without other neurological deficits was not identified in the study, although it has been previously reported. The presence of other abnormalities helped with neurolocalization in most cases, but mislocalizations still occurred. A combination of head turn, body turn, and head tilt is commonly known as torticollis or scoliosis, but similar terms have been used for cases with head turn, head tilt. The side of the head tilt was not always the same side as the head and body turn, making specific documentation of posture necessary. The most common imaging-based location in the study was the forebrain, where all but one dog had an ipsilateral head turned to the side of the lesion. The telencephalic cases mainly affected the frontal, parietal, and temporal cortices, which are important in sensory processing. In some dogs, isolated lesions in the basal nuclei were identified. An uncommon accompaniment to the altered head posture was a head tilt identified in 2 dogs. A head tilt and head turn in association with telencephalic lesions have not been reported in dogs. Dogs with brainstem and cervical spinal cord disease never exhibited a head turn alone, but always with other postural abnormalities. The interstitial nucleus of Cajal in the midbrain and the descending interstitiospinal fibers within the medial longitudinal fasciculus may contribute to posture of the head, neck, and body. Of the dogs identified with cerebellar disease, a large proportion localized to the rostral vermis, and all had an ipsilateral body, turn with a contralateral head tilt. The study had some limitations, including the pathology identified, which could be more extensive or infiltrative than apparent on imaging, making it difficult to ascertain which particular isolated cortices or areas could be responsible for a head turn. A larger sample size of lesions specific to one location would be needed to identify this possibility. In conclusion, the study identified a heterogeneous distribution of anatomical locations that give rise to the presentation of a head turn. The presence of a head turn upon neurological examination would not exclusively lead to neurolocalization in the forebrain, as historically thought. Any disruption of pathways could lead to postural deviation, as postural control of the head and neck is a highly complex system.